We will now hear from Mr. Reggie Tucker-Seely, who joins us from Los Angeles, California.
Great. Thank you, Jamie. So, the title of my story is What Health Justice Means to Me and my pathway to creating my own health equity consulting company called Health Equity Strategies and Solutions. As Jamie mentioned, my name is Reginald Tucker-Seely, and my pathway to working in health equity has been a non traditional one. I was a first generation college student. I have an undergraduate degree in accounting, and I worked in the accounting and auditing field for about 5 years. After leaving accounting and auditing, I got a master's degree in counseling and family therapy because I thought I wanted to get a PhD in clinical or counseling psych. While this degree highlighted that that was not the pathway for me, as a gay man who was newly out fully to myself, this degree program did help me to explore coming out in the other areas of my life. It was also during this time that I was working on my master's thesis for that program that I stumbled across the phrase social determinants of health. It was that phrase that would shape the next 20 plus years of my career journey and introduce me to the field of public health generally and social and behavioral sciences within public health specifically. I was fortunate to train in public health at the Harvard T.H. Chan School of Public Health, and I was at Harvard for about 15 years. I completed master's and doctoral degrees there, as well as a postdoctoral fellowship in cancer prevention and control at Harvard and the Dana-Farber Cancer Institute. I also stayed there as an assistant professor, where I developed and taught a course called Measuring and Reporting Health Disparities. At this time, I was also serving on the Rhode Island Commission for Health Advocacy and Equity. And this group was legislatively mandated to develop and publish the state report on health disparities. At the time, I had no idea how to write a state-level health disparities report, and I figured that if I didn't know how to do it, that many of our students in the department where I worked didn't know how to do it either. So with the help of our Dean for Case-Based Learning at the time, Dr. Nancy Kane, and her team, we developed a 3-part case study about my experience that took students through the process of writing a state-level health disparities report, where Part A focused on defining terms, Part B focused on selecting health outcomes and data sources, and Part C focused on methods for measuring differences. I loved teaching this course. And the best part was hearing from students after the course ended, when they were doing exactly what we did in the course in their work environments. And they could lead the discussion or effort focused on measuring and reporting health disparities in their work environments. This case study led to the development of the first draft of my framework for how organizations and committees and coalitions and communities could address health disparities in their respective communities. The students loved the course. I won a teaching award for the course, and the evaluations were always really good. However, I recall there was that one evaluation that wasn't as good. And it stated, while this course was a really good course, there was no focus on federal health disparities policymaking. Well, this was because I wasn't familiar with federal health disparities policymaking. So I looked for experiences or opportunities to learn more about federal health disparities policymaking, and I found 2 fellowships, the White House Fellowship and the Robert Wood Johnson Foundation Health Policy Fellowship programs. The RWJ Health Policy Fellowship program included a 3-month orientation on how federal health policy gets made, and then an 8 to 12-month placement in a legislative or executive branch in Washington, D.C. As soon as I learned that, I knew that the RWJ Health Policy Fellowship was the experience that would help address the lack of federal health disparities policymaking in my course. So I applied. Now, during this time, I was also recruited to the Leonard Davis School of Gerontology at the University of Southern California. I said yes to USC in December of 2016, and then in February of 2017, I was selected as an RWJ Health Policy Fellow. So for the 2017-2018 academic year, I was in Washington, D.C., and my placement was in the United States Senate. And since I was a new resident to California, I wanted a California placement. And I was fortunate to match with the office of Senator Dianne Feinstein.
Wow.
Now, this was the most remarkable career experience to date because I saw firsthand the policy pathway to change. And the silence at the federal level during this period related to health disparities was absolutely deafening. Now, fast forward to the spring of 2020, I'd been back in LA for 1.5 years, and then the COVID-19 pandemic hits. And as you will recall, during the spring or summer of 2020, several highly visible cases of police brutality against Black and brown folks also hit the news. The combination of the pandemic, the anti-Asian hate crimes, and the police brutality cases amplified discussions related to health disparities and systemic racism during this time. It was also during this time that I was starting to feel like my work was not having the impact I wanted. In particular, I was seeing folks on the news talk about health disparities in a way that seemed like they weren't aware of the decades of health disparities research. For example, the inequities we saw during the pandemic were no surprise to any health disparities researcher. Yet many on the news were shocked that racial and ethnic minorities, older adults, and those with fewer socioeconomic resources were hardest hit by COVID-19. This felt like an opportune time to leave academia and to pursue opportunities that would allow me to apply my research and policy skills to make a difference in the health disparities that were now being discussed more often. I saw several organizations at the time creating senior roles to develop and implement health equity strategy. And fortunately, a research partner of mine created such a position. That organization was Zero, the End of Prostate Cancer, and they created a VP of Health Equity role. I then interviewed for and was selected for this role. My responsibilities were to develop and implement the health equity strategy to address the disparities that Black men experience in prostate cancer. And given the newness of this role, I generally felt like I was all alone. I reached out to those with similar titles on LinkedIn to connect to and at least feel a sense of community and to learn what others were doing. And throughout my time in this role, I consistently realized that awareness about much of the research about the differences in health by race and by place had not made its way to communities. Of course, those communities understood that work because they were experiencing these inequities. But also, many organizations were struggling with what to do after they made that initial commitment to address health disparities or inequities in their communities. This is where I felt that the framework I developed from my many courses, informed by my community work as well as my policy experiences, could be helpful. So I decided to create my own consulting company, and I named it Health Equity Strategies and Solutions, with the goal of helping health-related organizations, departments, coalitions, and communities to move past merely describing sociodemographic differences in health and to begin developing, implementing, and evaluating health disparities elimination strategies in order to achieve health equity for historically marginalized populations. The framework starts with organizational commitment, where senior leadership makes a decision to address demographic group differences like by race, by place, by gender, in health or clinical outcomes, and they align on definitions for those key terms. The framework also includes steps such as outlining process for selecting health and clinical outcomes, methods for measuring differences, and also evaluating the impact of programs to eliminate disparities. And at the center of this framework is engaging with the communities experiencing disparities and organizing with those communities to achieve equity. Health justice means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to a usual source of healthcare and coordinated high-quality specialty care, and ensuring that families have the resources to manage their health and navigate the primary and specialty care delivery system. Now, those are nice words to say, but implementing health justice requires empowering communities to know that differences in health and healthcare outcomes exist, understanding the historical and current factors that contribute to those differences, and having the resources, both human and financial, to eliminate barriers and to create more equitable systems that work for all of us. Thank you.
Oh. Thank you, Reggie, for bringing us through that metamorphosis. I'm reflecting on the very different forms that we've heard over this session. Vanessa, something happened to her. There was suddenly a diagnosis of a serious illness, and she surmounted the impulse to to keep that quiet. And she surmounted it because she realized that others could use her help. So she went from her own situation to being a real force. She was running support groups for 40 women at a time. And it was within this one category of cancer, not just breast cancer, but and so that's a model of how what came to you, what called you. In her case, it was her own illness.
Mm-hmm.
When we heard from Chris, it was the illness of his mother,
Mm-hmm.
and how that illness transformed his trajectory.
Mm-hmm.
And he left the basketball that he loved,
Mm-hmm.
and he became a real diplomat
Mm-hmm.
for justice,
Mm-hmm.
totally, completely saturated. And then we heard from Mildred, who was in her specific community and knows only too well its limitations and its enraging
Mm-hmm.
systems of injustice.
Mm-hmm.
And no matter what they were able to do, were always, how can I say, irrevocable.
Mm-hmm.
And we saw it even just in the tone of her voice and the set of her head,
Mm-hmm.
how irrevocable those things were.
Mm-hmm.
And then you come with a whole other geography.
Mm-hmm.
And it's not one illness, one parent, one delta. It's like, what do we got here?
Mm-hmm.
With the capacity to move from, no, I don't want to be a counselor. I'm going to disregard that. No, I don't want to do this.
Mm-hmm.
But it wasn't dilettantish. It was moving toward the prize.
Mm-hmm. Mm-hmm.
And you have just managed to articulate the prize, which is knowing enough about the whole system to be able to intervene.
Mm-hmm. I would say I was going to say two things have really, informed my pathway. So as I mentioned, I was a first generation college student. I'm originally from Arkansas, and my family is actually from Eastern Arkansas on the border between Arkansas and Mississippi. And I would say as a child, I saw a level of poverty in that part of the country that has stayed with me.
Yeah.
That consistently motivates me to work towards
That's great.
ensuring that poverty isn't a barrier to high quality healthcare. And I think the other thing is the fact that I am a Black man and I'm also a gay man, so I'm managing multiple minority identities that I have to navigate the systems. With those minority identities, so I'm well aware of the barriers that also present for those of us that are navigating and managing with minoritized identities. Yes.
Yep. But the point here is how many different singular avenues there are toward a kind of triumph. And we've heard 4 versions of triumph. And we understand how powerful is our opponent.
Yes.
Agreed.
Jamie.
Sorry, Reggie, to cut you off, but yeah, I was just gonna chime in. As you were speaking, our organization and Reggie, we've known Reggie for some years now, but this is really the first time I'm hearing his entire trajectory towards where he is now. But as he was speaking, and as I was reading the story before the event, all I kept thinking of is if you want something done the right way, you do it yourself. And so that's kind of, I'm like, okay, Reggie. And I'm looking at the chat. We've got some similar sentiments. Melinda said, I love that you made a whole company in caps, dedicated to the cause. Kudos to you. Martha has said that Reggie loved how you rose to the situation. And Carrie shared incredible work, weaving all of your experiences and curiosities into such a positive impact on us all. Thank you, Reggie.
Well, this touches my heart so much because my primary program of research, which I didn't mention, was financial hardship and cancer.
Oh,
And I developed a model sort of looking at the financial hardship that families experience as they navigate the cancer care delivery system. And so if you look back on my career trajectory, it totally makes sense that that's my program of research. While I was in it, it was very stressful making all of those changes, so I don't want to minimize that. But I am so committed to doing this work to ensure that a diagnosis of a chronic condition is not financially ruinous to
good.
households, and bringing all of my skills hopefully to help with that.
Beautiful.
Thank you. Thank you so much.